तो आपका भी होंगे ना, वंदना बारह 17 तो दिखता है। आवाज चाहिए आपको? हाँ।
గట్టి చెప్పు మనిషికి. పులుసు బాగా కదిలిందా? బాత్రూమ్కి వెళ్తాను జీన్స్ దారిలోనా పక్కకు తిప్పు.
వాళ్ళే మ్యూట్లో పెట్టిర్రు.
అసలు నువ్వు ఎలా జరుగుతావు పక్కకి మనిషిని? ఏమో శివరామయ్య బాత్రూంలో పడేస్తాడు, మంచం మీద పడేస్తాడు. బాత్రూంలో పడేటందుకు అదే ఉచ్చపోసుకుంటున్నా డైపర్ ఉంది హాస్పిటల్లో చూసుకుంటున్నాను. బట్టలు మార్చుకుంటాను శివరామయ్య కుదిరేగా మార్చుకున్నా అసలు పోదు. హాల్లో ఆడతాడు కదా కొంతమంది దాని మీద పడేసేస్తుంది. అప్పుడు చెప్పాల్సింది అప్పట్లో కొడుకు లేదా వాళ్ళు ఏం చేసినా బాగానే ఉంటది. వేరే వాళ్ళు ఏం చేసినా అమ్మో 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 ఇంకాను మమ్మల్ని అలాగన్నారు ఇలాగన్నారు అంటారు. మనుషులు పెట్టుకుని మనుషులు పెట్టుకుని చాలా చెప్పుకొస్తున్నాను. మీకే మనిషి ఉంటుంది ఎవరు చేస్తారు ఎవరు నాన్న ముందలుగా ఉంది. నువ్వేమన్నా వినపడదుగా. అదే అంటే ఉండదే అది ఇది ఎక్కువ మార్తి ఉంది కదా అది కరెక్ట్ కరెక్ట్ అన్నాడు. నేను కరెక్ట్ అప్పుడు నుంచి ఎక్కన్నాడు బాబాయ్. నేను 100 సీట్లు కూర్చుంటాను. అయ్యా మా పక్క సీట్లో కూర్చుంటా అన్నాడు. నిప్పి పక్క కూర్చోవాలి కదా. గంట ముందే వచ్చేసాయి. అదేదో వచ్చి మంచాలు గంచాలు అన్న రెడీ చేసాడా? ఏం పెట్టలేదా? మంచాలు బట్టలైతే వాషింగ్ మిషన్ తీసుకుంటారు. అప్పమ్మని తెచ్చుకోవద్దామో తెలియవండి. ఎన్ని రోజులు ఉంటాను. నా తాతయ్య తీసుకున్నాక అడిగాడంట 200.
Hi, good afternoon, everyone, and welcome to Ipc Master Class session 2. So we are really very happy seeing all of you joining this forum for infection prevention and control. So without much delay, let's get started. So first I take this opportunity to introduce our session chair, our moderator for the session, Dr. R. Sukanya. Welcome, Doctor, to this forum. And so I'll just take a brief, I'll give you a brief introduction about Dr. R. Sukanya, who is a very well-known infection preventionist across the country and the world, of course. So Dr. Sukanya is an MBBS and MD in clinical microbiology with certification in infection control from CBIC USA. And she has over 16 years of experience in clinical microbiology. And she is also a certified internal auditor for NABL and NABH. She has been into JCI audits, NABH audits, and NABL audits. She also takes a very keen interest in research work and has published journals in peer-reviewed journals of very high repute and high impact factors. She has also been the organizer for a good number of CMEs, training programs, quizzes, and IPC, AMS, and also research projects. So currently she is associated with MedGenome as a consultant microbiologist. And apart from her affiliation with MedGenome, she is also a consultant part-time trainer at Care Institute of Health Sciences, Hyderabad, for infection prevention and control courses. She is also a part-time consultant to clinical microbiology and infectious diseases for MedGenome. And she is also a faculty for Diploma in Infection Prevention and Control by IFCI and University of Hyderabad. And she is also the national faculty for IPC and WASH training and mentorship program by UNICEF India and CDC in collaboration with ASCII. And also notably, she is also won the Asian Healthcare Management Gold Award for physical involvement in AMS in 2017. So welcome, Dr. Sukanya, for IPC Masterclass Session 2. And with this, I hand over the session to Dr. Sukanya. The platform is all yours.
Thank you, Mr. Lalit, for the generous introduction. Thank you so much. It's always a pleasure to be associated with SANMED, especially in association with master classes. I think you would have seen, all of y'all, when Mr. Lalit was presenting, that we've had a series of masterclass webinars on IPC, and I've been associated with this masterclass event for all the 5 sessions, and it's really been an enriching experience. So without wasting much time, I would like to warmly welcome our speaker for this session, who's Dr. Jaya Banerjee. It's my pleasure, really, to come to know of such colleagues and peers in IPC. So Dr. Jaya Banerjee basically is a consultant microbiologist, as well as an ICO, infection control officer, and an antimicrobial stewardship lead, as well as an internal auditor at Yashoda Hospital, Secunderabad. Okay, so ma'am has a lot of certifications in infection prevention and control from JIPMER, from the New York State Health Board and Inflexon Academy. She is also certified in antimicrobial stewardship by CAHO, and also has received certification as an internal auditor for both quality management systems as well as for NABH 5th edition, okay, 5th edition standards. Ma'am has also received a fellowship certificate in diabetology from the Indian Medical Academy, and also has a PG diploma in her basket of accolades in maternity and child welfare from IGNOU, right? She has published several articles, and she's, I think, an avid teacher as well as a researcher. 7 articles in peer-reviewed journals, of which 4 of them are original research articles and 3 are review articles. Excellent. And also has presented several papers and posters in national conferences, right? Dr. Jaya has also faced several audits, which obviously has enriched her experience, like NABL, NABH, as well as Green OT and ER excellence audits, which I think is a very good experience for all of us, the learnings from that, and has been instrumental in the DNB renewal audit at her hospital. So with this very short, I had to cut short because there was too many things. I think you will see the way she speaks, and please interact with her. That will be a great learning opportunity for all of you. I warmly welcome Dr. Jaya Banerjee on this platform to please proceed with the session. Thank you. Dr. Jaya is there?
Yes, she's there, madam. She's on mute. Madam, you can unmute and.
Okay. You're muted. You're muted, ma'am. No, you're not audible.
Dr. Jaya, can you please unmute yourself? Yeah, you are unmute now.
Now is it okay?
Yes, fine. Please proceed with the session, Dr. Jaya. Thank you.
Thank you, ma'am. Is it shared, ma'am?
No, it's not yet shared.
What shall I do actually?
Can you do, have you gone to screen sharing?
Doctor, there is a icon at the bottom of the screen with an up arrow key called as present now.
Where exactly?
It is, yeah, now it. Someone
Okay,
else.
full screen? Share screen. Share screen. Okay,
Yes.
Share option.
Dr. Jaya, there are a few icons down at the bottommost portion of your screen. Can you see that? There is a hand as well as a up arrow.
Hello.
Yeah, up arrow is there.
Up arrow, if you press it, it says present now. You can press that.
It's coming as your entire screen, a window, a tab.
ఇంకా రాలేదండి, అది టైం పడుతుంది. ఇప్పుడు మేము సెషన్ లో ఉన్నాము.
You take the entire screen.
Okay. Entire screen share.
And then you can go to the PowerPoint.
Share.
It's not getting selected.
It's not getting selected.
Should I share from my side?
No. It's because changes has there. नहीं आ रहा है क्या, एक बार देखो ना जाके पूरा.
Dr. Jaya, otherwise, can you mail the changed presentation to Mr. Lalit right away now? And
Okay,
maybe-
fine.
Yeah.
साउंड कम कर सकते हैं.
Doctor, are you sharing it with me?
करना भी आसान करेंगे. इसके साथ इसको कनेक्ट कैसे करें? I have sent.
Okay.
One second.
Directly can go.
Yeah, I just received it.
Okay, fine.
Downloading and sharing it.
My voice is audible there?
Yeah. It's
Is it
perfectly
fine
audible.
if I talk without this microphone?
You are audible.
You're audible now. Dr. Jaya, you're audible.
इनमें जाना पड़ेगा. ये इसको क्लोज कर ये सब ये कहाँ से है? जॉइन मीटिंग.
ये है?
नहीं जॉइन मीटिंग उधर फिर से उधर जाना पड़ेगा ना. ये क्या है? Shall I again join?
Yeah, you can just start with the introductory part while I'll download it and play it.
No, I'm not able to see anybody actually.
But we are all able to see you.
You can see? Can you see me?
Yeah, madam, we all can see you.
All of us can see you.
I'm not able to see the screen actually, so I am not able to start. Anyway, good afternoon,
Dr. Jaya.
everyone.
Yeah, good afternoon, Dr. Jaya. Don't get flustered. It's okay. I think it's not a technical glitch. It always happens. Most of the times, it's
Technical
okay. You can just
glitches.
continue. You can start off with your slides if you have them on your screen, and we can pick up from there.
Yeah, I did not get one.
Okay. Yeah. You can see me?
Yes.
Okay. Yeah, please start with introduction. Yeah, I think it's come right for you.
Okay, yeah. So, good afternoon, everyone, and I welcome all attendees who are attending this session. I would like to thank Mr. Lalit and Sandmet Company for giving me this opportunity to talk about this evidence-based standard precautions in infection prevention and control. I am really feeling myself blessed and get an opportunity because this is we all know that infection control and prevention and control week is going on, and we got this opportunity for this to talk about the same topic in this week. So it's really fortunate, I feel. So first of all, I would like to tell that presentation is about the many things. My topic, what I have got, this is standard practices in infection prevention and control. It's a very big, huge topic, and it's really difficult to justify within 1 hour. But I will start, I will try to complete all the aspects, we try to touch all the aspects. So starting with my presentation, what all the presentation is showing in the next slide. Change, please. So these are my presentation objectives: to understand the basics of the infection control program, insight of the routine HIPC practices, different type of precautions, to know the implementation of the transmission-based precautions, device associated and process-related infection supportive services. Excuse me, madam, is it vibrating or something? Because I'm getting some vibration kind of.
Yeah, I think you've logged in from 2 systems. Is it Dr. Jaya? Because 2 of your images are there. I'm not very sure. Have you logged in from 2 devices?
1 minute, ma'am. Most probably 2
or 2 windows or something you opened.
How do I log out? Ask how do I log out?
How do I log out?
You'll have to leave the session and join in again with the link.
You can just press the bottom red key on the right from any one of your windows or your device. You will log out. Yeah, it's logged out.
Now again I have to enter.
Yeah, now actually it's fine. There's only one image of you. Okay, you can continue like this.
Okay.
I think now it's not echoing. If you can talk, right?
Echoing is not there, but yes. I'm not getting that my presentation. I'm not able to see.
Okay, then ma'am, just log out. Again, press that again, once again, and log out and again rejoin.
इसमें से खींचिए ना.
इसमें से नहीं होगा, बता नहीं पाएंगे. इसको प्रेस कर दो. अभी फिर again I have to go there.
Yes, the bottom red.
Join with Google Meet, right?
That's right, but you need to log out of this session because we can still see and hear you. So you're not completely
logged out. When I go out,
you leave call, hai na? It is down. There is one red button called leave call. If you just put your mouse on
in the meeting.
Yes.
Continue. No.
Bottom most there's a red button, ma'am.
Where is it? Shall I go out and again I will start?
Yes, ma'am. That will be better.
किसी को बुलाओ ना प्लीज, कुछ समझ में नहीं आ रहा है, सब चला गया.
You can leave and again log in, ma'am.
कैसा करना है?
Leave down. नीचे एक रेड बटन है ना, एक जो फोन की तरह है, लाइक.
मैडम मेरे पास सिर्फ इसका ज्वाइन द गूगल मीट का एक खाली मिल रहा है, कुछ भी नहीं मिल रहा है.
Dr. Jay, can you please take the call?
Hello, join a meeting I am getting.
Okay, Dr. Jay, do one thing. Close this window wherein this meeting is there. Close it.
ओहो, అమ్మా పైకి రా, మా కబుర్లు చెప్పుకుందాం. పైకి రా, కబుర్లు చెప్పుకుందాం.
Madam, you please unmute your phone on your side, madam.
Dr. Jaya, please unmute yourself. We are unable to hear you.
Yeah, now I am getting here.
Yeah, now we can hear you. Thank you. Please continue.
So these are my presentation objectives, and it is very difficult to cover all the topic, but still I am trying to cover every thing, all the aspects. So next slide. So regarding the what is infection prevention and control, we are talking about so much about the infection control. What is that? Infection prevention control is just an ongoing process which consists of various programs, and it is basically focused into two broad goals. One is to increase the patient safety by reducing the risk of acquisition
Excuse ma'am,
the infection.
आपका sound is breaking, ma'am.
Any problem?
Ma'am, your sound is breaking. It's not proper.
Is it okay? Fine?
It's okay, madam. It's fine.
It's okay. It's
Yes,
fine.
It's fine.
It's fine.
So it focuses two broad goals: to increase the patient safety by reducing the risk of acquisition or transmission of the infection following the exposure to the healthcare settings, and to reduce the risk of device associated and procedure related infections. Next. So when we talk about the infection, first comes the chain of infection in our mind. So we all know this chain of infection as the infectious agents, reservoirs, portal of exit, and transmission, portal of entry. So each and every chain we can cut down, or we can break, and we can stop and prevent the infection. First of all, if we cut the infectious agent, that could be viral, could be bacterial or parasitic, so it will itself it will not come. A portal of exit or portal of entry we can cut short or break down by the use of PPE. We can reduce that infection chances by the for the reservoirs by giving the immunization. Like this, all the six chains can be breakdown, and transmission can be stopped at there. That is the called prevention and control. So first is that is called prevention actually. Next. So types of precautions include standard precautions, transmission based precautions, and prevention of device associated and procedure related infections. Next. Coming to standard precautions, next. There are set of standard precautions are the set of practices which is used to minimize the transmission of healthcare associated infections. It applies to all healthcare providers regardless of the infectious status of the patients, and to ensure a basic level of infection prevention and control. It consists of few components which includes hand hygiene, personal protective equipment, safe use and disposal of sharps, require routine environmental cleaning, and then respiratory hygiene and cough etiquette, reprocessing of reusable medical items, biomedical waste management, and appropriate handling of linen. Next. So coming to the hand hygiene, starting. So we all know that is WHO has given us fantastic simplified recommended indications for the 5 moments of our hand hygiene. That is before touching a patient, before clean and aseptic procedures, after body fluid exposure, and after touching a patient and after touching the patient's surrounding. So we already know. Just we would like to refresh a brushing of the this knowledge. Next. Now the steps of hand hygiene. We know that is hand hygiene is hand rub and hand wash. Hand rub is around 20 to 30 milliseconds, whereas hand wash is 40 to 60 seconds. So steps also almost we know, and WHO guidelines for the hand hygiene healthcare. Almost everyone, we know these posters. The only thing is we are doing the hand hygiene, we are doing hand washing. Just normally if we do, these red areas we will miss. And that is the reason this following the 7 steps of hand hygiene and rubbing is mandatory. Next. We have to little faster. Madam, now it's audible or is breaking anything? Sound is breaking?
No, madam, it's fine. It's going on.
Clear, ma'am, now. It's clear.
No, if you want me to put some this microphone or something?
Now it's really clear, ma'am.
Okay, fine. So hand hygiene, the general instructions or thumb rule we can say, that is nail brushes or the artificial nails are not recommended at all. The second is the gloves are not a substitute for hand hygiene. It gives just a false impression or false sense of being aseptic. And cloth towels is strictly prohibited after drying, for the drying after the hand washing. It's strictly prohibited. Next is what are the products available? Hand wash products are the plain soap. Hand rub products can be alcohol-based hand rubs or the chlorhexidine hand rub. And there is a synergistic effect when we use the alcohol and 2% chlorhexidine. Many organizations use in the high-risk areas this synergistic effect. Next. Now surgical scrub. First surgical scrub of the day should be 3 to 5 minutes with the subsequent washes for the 3 minutes between the surgeries. But most commonly used antiseptics are chlorhexidine followed by the povidone iodine. Alcohol-based surgical scrub scrubs can also be done with, we have that knowledge that always we should do the surgical scrubbing should do with the hand washing, but WHO has given that surgical scrubs can be done by hand rub also. For that, 15 ml of alcohol scrubs to be used and applied for 3 minutes. Then only it will be efficient, and it will be almost the same as the surgical, not almost, it will be the same as the surgical scrub by the washing. The next, the beautiful pictures. This picture presentation has given by WHO, and these are the pictures. So first what we have to do, we have to take the hand rub around 5 ml in the left hand, and we have to put our nails for 5 seconds in that, and then we have to first put everything up to this elbow, this 5 ml solutions. The next 5 ml, this will be again the opposite hand, and we will dip our left hand, next in the left hand 5 ml, 5 seconds in the 5 ml, and after that we will put up to the elbow. The next will be 5 ml again we will take, and the common normal hand rub, whatever that is palm to palm, back of the palm, interlacing, interlocking, finger thumb rotation, and tip of the fingers. The same way we have to do along with the wrist. So these are the these things are given by the WHO. Next. So hand hygiene compliance monitoring, how will you do? We can do by observation, by measuring the product use or conducting the surveys, but the gold standard is always the direct observations by the observation tool provided by WHO. Next. Hand hygiene complete adherence rate or compliance rate can be achieved by number of times. We can calculate by number of times of hand hygiene followed by the number of opportunities we have seen into 100. Next. So evaluation of efficacy. How can we see what is the efficacy of the hand hygiene products? It is by European norms or American Society of Testing and Material Norms. These are the test organism used for testing the hygienic hand wash or hygienic hand rub or surgical hand preparation. Next. So before starting to PPE, madam, I think this is not audible. Many people are leaving. So can we do anything, something?
It is audible to me. I think there's no problem. Yeah. There's no audible.
It's audible, ma'am. It's audible, ma'am.
I don't know, but gradually they are leaving. So anyway.
It happens in all the
sessions. Is it clear or some sound to be increased or something? If you guide me, I can try it.
No, ma'am, you're perfectly audible and very clear. There's no problem at all. I don't know why. Maybe there is some issue with your servers or something. There's no other problem, ma'am. Your presentation is very clear.
Okay. And properly visible the slides and myself?
Yes, ma'am. Yes, no problem.
Continuing with the PPE. So next slide, please. So with the definition of the next slide, definition of PPE is the specialized clothing or equipment worn by the employee or healthcare worker for the protection against the infectious materials. Main objective is to protect the skin and mucous membrane of the healthcare workers, as well as to protect the patient from the contracting the infections from the healthcare workers itself. As we know, the many PPEs are available, starting from the masks, gloves, head caps, gowns, full gowns, coveralls, shoes, but everywhere we need not to wear every time everywhere. It's a matter of we have to anticipate. The next slide, please. We need to anticipate which is the right PPE, when to use. So PPE should be used appropriately, used only in the protected environment, should not be worn outside the area, and type of anticipated exposure, type of isolation precaution is required for the patients. And gowns, aprons protect the skin. We all know, we are not going into detail. Only one thing I would like to emphasize, that gloves protect the hands of the healthcare workers and patient. and not a substitute for hand hygiene. Next. No, madam. Hello.
Yes, Dr. Jaya.
After one, something is. I know what is happening.
No, what happened? It's clear. There's no problem.
So maybe it's not going beyond the connective areas. I mean, you and me is in a loop, right? And it's going outside. It's not going outside. Something happening?
Mr. Lalit, is there any issue with the other participants? So technically,
No, ma'am, it's clear, ma'am.
it's clear, right? Okay. Okay. Thank you.
Okay, so next is the use of masks. So I should not bother about that. Okay, leave it. So masks should not be worn with the beard or unshaven face, or they may interfere with the N95 fitting. One thing I would like to say in the mask, about mask, many things we know, and we should not go into details, because of, I think, because of COVID only, we every people has come to know the what are the types of masks, when to wear. Only one thing here I would like to emphasize about the fit testing and fit checking, where you are using N95 mask. So placement of the respirator like this, and we have to inhale and exhale. Inhale, when inhale, it should not go inside, the mask should not go inside, and where we are exhaling, it should not, the air should not come from here. So these 2 points we have to check, and fit testing and fit checking is must. Next. So gloves also we know indications, that is blood and body fluid exposure, mucous membrane, non-intact skin, or other potentially infectious materials. When the patients are in the risk of the contact precautions, that is the methicillin resistant Staphylococcus aureus or VRE or RSV, all these things, then gloves must be used along with a gown. And when the visibly and potentially contaminated patient care equipment or environmental surfaces, gloves has to be used. And change in between the patients, we need to change the gloves. And the second, like same gloves, we cannot take care of one patient and then the other patient at the same time. When we are taking care of one patient only, but one is the dirty area and one is the clean area, we cannot we use the same gloves from the dirty area to clean area. For the same patient also, we should change. Here I would like to add one thing more for the hand hygiene, hand washing. When we should go only for hand washing. Hand washing is particularly when the hand is visibly dirty, after using the washroom, and before having the meal, and when the your patient is having the risk of Clostridium difficile or MRSA or VRE. These areas we cannot replace the hand hygiene by hand rubbing. Only hand washing we have to go with. Next. Use of gown and coveralls. Indications. We know gowns we have to use with the contact or blood body fluids, already discussed. And precautions, we have to ensure that availability of several sizes, along with the totally cover the arms and body front from the neck of the mid thigh. And here also European norms is there for the efficacy of the gown or coverall. I'm not going in all the slides, all the words, because time is less and we have to finish many slides. Next, kindly little fast. And these are the sequence of donning and doffing given by WHO. The next slide I will must be appropriate donning, hand hygiene, then gown, mask, then goggles and gloves. Whereas in the doffing, gloves, hand hygiene, goggles, and then gown, then mask, and lastly hand hygiene. Hand hygiene means hand washing. Sometimes double gloves also can be used. The first gloves will be removed, and the last gloves again after mask or respiratory removing, we can remove the gloves, and hand hygiene we can do. Next, please. So buddy system. What is buddy system? It is to observe the donning and doffing of the PPE, which is recommended. A buddy system, it doesn't means to find out the error of the error of the doffing person. But the thing is, it can collect, it can find out any damages are there in the in the PPE or not, or it can find out whether it is they are doing properly or not. Sometimes on-site buddies are not possible because of unavailability of the many nursing staff or many buddies. So that time off-site also can be acceptable. The remote buddies, they have given name. The remote buddies can view the procedures via video conference on their computers and can see. Next is standard precautions, safe use and disposal of subs. As soon as this name came, that disposal of subs, first thing comes in our mind as a needle stick injury. So thumb rule, we should follow the thumb rule that do not recap the needles. If you want to recap, use a single hand scooping method. And second is do not pass the needle from one person to another. The most common cause of the needle stick injury is the improper handling and disposal. So 3 major blood-borne infections are transmitted through a needle stick injury. We all know HIV, HBsAg, HCV. First of all, next, please. So use of vacuotiners and holders. Never recap the needles. Always carry a tray while doing any procedures. Safe handling, proper segregation, and immediate disposal of subs. Use of separate containers for the sub segregation. Use of gloves. These can prevent the needle stick injuries. And as a precautionary measures, we can do the proper hand hygiene practice, and all healthcare workers. Hello.
Yeah, Mr. Satvir, can you please stop presenting? Mr. Satvir Singh? Yeah, thank you.
Sorry, ma'am. Sorry.
Yeah, please mute yourself.
Okay. Please continue, ma'am. Sorry.
I'm not getting my slide.
Let you start, you present again. You have been removed from the presentation.
What happened?
So Lalit is starting, madam.
Okay, so next slide, please. Coming to the routine environmental cleaning is very important, and it is almost it's same as a housekeeping cleaning. There's a important, very basic things. So I have taken the guidelines from the environment cleaning from the CDC and Kayakalp initiatives. Next. General rules for housekeeping we should follow. This: never shake the mop. Broom should not be done, and always go from low touch surfaces to high touch surfaces. Patient areas from patient areas to the patient surroundings. We to prevent the dirt and microorganisms from bed rails and bed legs. So all these things we have to follow the same way. Next slide, please. This is another important thing, 3-bucket mopping system. Here, normally what we do, that is cleaning and disinfection we say, but cleaning doesn't happen, only the disinfection happen. But if we use this 3-bucket system, the first bucket will contain the cleaning solution, and then this mop, with that mop, we can rinse in the second bucket, and third is the disinfectant solution. At the same time, we can do all this along with the cleaning and rinse and disinfectant solution. And at the same time, we would like to emphasize one more important, very important thing, that is cleaning in the hospital area. It should be always 8-stroke technique of mopping is recommended. And because of the wet flow, fall can happen. The wet floor signage should be added. Next. So the checklist for high touch surface cleaning, we can incorporate in our facilities also, like this. This is a sample checklist. Next. Coming to reprocessing of reusable medical equipments and instruments. Next. Yeah, Kayakalp has given a very beautiful details of the cleaning frequency and disinfection levels. And here it's a sample. It's a few areas are mentioned, but if you go through this guideline, you can get each and every area how to clean, and what frequency you can clean, like what frequency is required, which kind of disinfection level is required. Everything is given in a detailed in Kayakalp implementation guidelines. Next. So first I will tell the types of disinfectants. We know the sterilization, but after the sterilization, just down the sterilization, the type of disinfectants are high level disinfectants, and after that intermediate and low level. So high level disinfectants includes glutaraldehyde, orthophthaldehyde, peracetic acid, hydrogen peroxide. Intermediate level disinfectants include sodium hypochlorite, povidone iodine, and so on. So coming to the next slide. This efficiency of the disinfectants. How can we see the disinfectants? First is the sterilization. I will describe only one line. That is the spores or unenveloped viruses, fungi, mycobacteria. All will be can be sterilized by the sterilization, can be killed by the sterilization. Whereas in the high level, some of the spores, but the rest of them can be killed. Intermediate and low level, most of them are not killed. The mycobacteria can be killed by the intermediate level. So these are the things, how we are changing how we are using the disinfectants. Next, please. So resistant to microorganisms, to disinfection and sterilization, it goes by the resistant to susceptible. Right side, you can see the level of sterilization, high level, intermediate level, and low level. Next, please. When coming to the equipment cleaning, we always comes one thing, that Spaulding's classification, patient's contact and device classification, and examples reprocessing. So these are my parameters I have written. Here, sterile areas of the body or vascular system is considered as critical. If we go up, like critical is down here. So if we go up, the critical sterile areas of the body or vascular system is a critical area, and it is sterilized by the sterilization. The next is the semi-critical, where the mucous membrane and non-intact skins are the touching part, like endoscopy. So endoscopes can be sterilized by disinfected, high level disinfected by the glutaraldehyde. Commonly we use 2% glutaraldehyde, high level disinfection. Similarly, the last is a non-critical, like the non-normal skin contact, like blood pressure instrument. So those can be intermediate level disinfection, can be by the low level disinfection or intermediate disinfection, but we prefer low level disinfection, like sodium hypochlorite we use. Next, please. This is again the checklist for the equipment cleaning we can use, and we can customize according to our organization policy. Next. Glutaraldehyde efficacy must be checked. Glutaraldehyde, once activated, it can be used for 14 days, and it should be checked each and every soak of the item we should check. And here the glutaraldehyde chemical indicator strips as a acceptable and rejectable. You can see that is how, when we can accept, when we can reject. Next. Now coming to the, till now we talk about the sterile disinfection. Now we are talking about the sterilization. It is totally depending upon the CSSD, the heart of the hospital, any organization. So here it's a unilateral flow, unidirectional flow, soil zone to clean zone and to sterile zone. Next, please. Here the flow is, the guidelines or standards of disinfection and sterilization we have taken from the Center of Disease Control Prevention, and these are my guidelines for this sterilization standards. Next, please. So particularly the sterile process, how the sterile flow process is there. So first is the decontamination in the CSSD, and next is the prick and pack, drain water, dry and pack as appropriate. Then disinfection of the semi-critical items, sterile, use and appropriate physical and chemical methods. This is very important. We will talk about later about this. And then store in the sterile storage area and issue wherever is required in the OT or the ward or the ICUs. The small packs we use to send from the issue areas. Next. Sterilizer is steam sterilizer, ethylene oxide sterilizer, and plasma sterilizer. So it's not necessary that all organization have all the sterilizer, but according to their infrastructure or according to their resources, they can have the sterilizer, but the indicator must follow. Next, please. So sterilization indicators are physical, chemical, and biological. Next. These are the physical, that is the temperature and pressure. Next. Chemical includes these biotic tests and the process indicators. Next. These are the biological indicators we must use for all the implants, and whenever required, the biological indicator is particularly for the plasma sterilizer. In each load we have to use. Geobacillus styrothermophilus is for the steam and for the plasma sterilizer, whereas the ethylene oxide, that is ETO, we use Geobacillus atrophius. Next, please. Respiratory hygiene and cough etiquette, cover the nose and mouth. We are very well versed with because of this COVID. So practice hand hygiene after contact with the respiratory secretions. Please, next, please. Standard precautions about the biomedical waste management. We have the newer guidelines in 2016 with the amendment in 2018 and 19. Next. So this is in a healthcare waste. Around 80% are non-infectious and 20% are hazardous. But when this hazardous to infectious comes with contact with the non-infectious, it all becomes 100% becomes infectious. So we have to take care of the segregation at the point of generation. Next, please. So components of the biomedical waste management: generation at the hospital, that means at the source, segregation at the source, wherever it is working. Next is the collection and safe storage, and the transportation, and further the treatment and disposal for the on-site. We usually send by here, the Medicare, Isnapur is a third party, where the actual disposal is happening. The treatment is happening. Next, please. So segregation, we almost everybody knows that is yellow bin and red bin, blue colored bin, and white PPC. Next. Here, these are the disposal. Here, two things are important. One is that is yellow. Yellow is again yellow chlorinated plastic chlorinated bag has a biohazard symbol along with some cytotoxic chemicals or cytotoxic drugs when we send it. So here, that is cytotoxic symbols must be there. And one second thing is the yellow. Yellow, we know that is all the soiled items goes, but and the plastic all goes into the red. But when the comes to the blood culture, blood bags and the microbiological culture, it is recommended to do the pre-treatment by autoclave and send it into the yellow. These are the two extra points or additional we should know. Okay, the next slide. So handling of the waste bag, when it is 3/4, we should stop. It should. When the handling of the waste bag, it's 3/4 full, it should be closed. And when we are taking for the transportation, it should not be overflow. It should be covered properly in the closed manner, and then we should send. Next. Coming to the last point of the standard precautions, that is linen management. So these are the basic principle that is used in the linen in the appropriate bags. Contain the linen in the soiled bag. Do not rinse or sort in the linen in the patient care areas. Handle all the linen with minimum agitation. Separate clean the soiled linen and transport them. So wash woolen blankets separately. Autoclave the linen before supply to the operating rooms. Next. This is the classification of linen. How we classify or how we segregate the linen as a dirty and solid soiled. Dirty linens are it is used linen but not visibly soiled with blood and body fluid, whereas the soiled linens are known potentially infested linen. And most importantly, soiled linen, those linen which may not be soiled but blood and body fluid mixed, but patients are having the diseases like hepatitis A, B, or salmonella, HIV, or tuberculosis, or MRSA. Next, please. So this is the linen management flow and what is to be done and not to do. So sharp is like appropriate bagging. At the first of all, at the site we should not, at the site of the patient we should not shake the shake the linen. We should cover it into the proper proper yellow bag, and it should be covered properly. And once we know that patients are MRSA or VRE or patients are HIV, we should keep it separately with the labeling. And we should issue the linen to be close to the body and drop the linen at the floor, and we properly segregate, that is soiled and which are not soiled but clean, not clean but the soiled. Next please. Transmission based precautions. So we have completed the standard precautions. Now transmission based precautions. It includes, next slide, it includes the contact precautions, and second is the transmission based precaution. And the transmission based precautions is again that is airborne precaution, direct contact transmission, indirect contact transmission, airborne precautions, and aerosol formation. Next please. Direct contact transmission occurs when the microorganisms are transferred from one person to another with a contaminated intermediate object. So blood from a patient contact with mucous membrane or breaks or cuts the skin. So with the shaking the hand also it can happen. Indirect through any some object, intermediate object. The cross contamination can happen through the devices, or even the shared toys also can cause the transmission of the respiratory viruses. Next please. Coming to the contact precautions, what we should do. Particularly it happens when MRSA, VRE or CRE, carbapenem resistant organisms or Clostridioides difficile, all this comes. Here we should follow where we should wear the gown and gloves and thorough cap, everything, so that we can prevent the contact precautions, and patients should be in the cubicle or in a contact isolation, standard isolation room. Next please. Droplet precautions occurs when the respiratory droplets carrying the pathogens travel through the air from the respiratory tract of infectious individuals to the susceptible mucosal surfaces of the recipient. Next please. So here we need not to wear N95. We can use the surgical mask. We can, and if it is possible, N95 is fine. But here the products, aerosols, not aerosols. These are the particles. The particles goes beyond the 3 feet or more than 1 meter. So here we can use a normal surgical mask also. Next please. Patient must be separated. And last is the airborne transmission, where these particles goes beyond 3 feet or 1 meter, and there is a very small aerosol, so they can move here and there. For this kind of patients, we should use, that is airborne infection room, especially particularly negative pressure isolation room is ideal for them. Next. So these are the common examples of airborne transmissive diseases. We always prefer airborne infection room, or called AIR, where the special air handling ventilation is there. Personal protective care includes, protective equipment includes N95 for definitely we must, mandatory is N95 mask over here. Next please. Now coming to the third part of the presentation, that is the device associated and procedure related infections. What are the device associated infections? That is catheter associated UTI, central line associated bloodstream infections, and ventilator associated events or ventilator associated pneumonia. Coming to the bundle care for the devices. What if we want to prevent the device associated infection? We have to take care of the bundle cares. A care bundle is a collection of intervention that are evidence-based, bundle has 3 to 5 elements with strong clinician agreement. Each element is relatively independent, applied to definite population at one time. It follows all or none law. That is, if you follow all the compliance, all the bundles, it will be 100% compliant. But if we leave one also, it can lead to the healthcare associated infections. Next. Why we are doing the care bundles? All clinical staffs know that these interventions are best practices, but frequently their application in the routine care is inconsistent. So a bundle care means to ensure that application of all the interventions is consistent for all patients at all times, thereby improving the outcomes. Next, please. So coming to the prevention of COTI. What are the risk factors? Risk factors include the device-related risk factors, that is type of catheterization, indwelling catheterization, patient-related risk factors, including that female gender or older age, diabetes, urethral colonization, poor personal hygiene or fecal incontinence, and caregiver also failure to adherence the aseptic technique. In the hospital environment, more commonly the caregiver-related risk factors or sometimes device-related risk factors happened. Next, please. So for the bundle care, considerations prior to catheterization we have to give. Then we have to consider during the catheterization, whatever the faults we should not do, and consideration we need to do for the catheterization during catheterization and post catheterization. Means if we see here in the pathogenesis from the urethral meatus, we are putting the Colles catheter in the meatus. So during the sample collection, it can happen the breach in the bundle. It can happen a breach can happen when the urobag is up above the bladder level. All this breach can happen, and that can lead to the COTI, development of COTI. Next, please. So we have a bundle care for the insertion bundle care and maintenance bundle care. So we have already listed here, that is insertion bundle care, and maintenance bundle care includes daily catheter care, catheter always properly secured, drainage bag, closed drainage bag is used all the times, and daily assessment for the readiness of the removal of the catheter, and the while collection of urine from bag, hand hygiene and gloves change between the patients. So ideally urine should not be collected from the bag, but many a times collection, and the urine should be collected from the bag, and the same urinals if we use, that also can cause the infections. Next. So for the insertion care bundle and the bundle care audit, we can use this kind of form, and we can customize according to our organization or our facility. Next, please. And coming to the CLABSI bundle, we have insertion bundle criteria, which includes hand hygiene and glove, selection of insertion site where we are inserting. Next is the maintenance bundle care. Insertion bundle care, one more point is important, that is chlorhexidine is preferred for the skin antiseptic. Catheter must be properly secured after the placement. Coming to the maintenance of the bundle care, obviously hand hygiene and alcohol hub decontamination. Most commonly we see that alcohol hub, that is scrub the hub, is breached, and that is the major cause for the central line associated bloodstream infection development. Daily decontamination of local sign of infection, and the change of dressing with 0.5% chlorhexidine, daily assessment for the readiness. These are the maintenance bundle criteria. If we follow this properly, we could prevent the CLABSI development by 90%. Next, please. So these are the high risk procedures. Sometimes we are unavoidably, we get this kind of central line insertion. We cannot change by that time. That is in the emergency insertion or in the femoral line, because it's a wide bow line. It can cause the infections very frequently. Then non-tunneled insertion or multiple lumen insertion. These are the most common causes of the high risk of development for the CLABSI. Next, please. Central line management maintenance bundle. This kind of bundle checklist is to be prepared for the bundle care audit. Next, please. Prevention of VAP or ventilator-associated events. It has a general measure of approach and a specific approach. These are the general measure, that is education and training, surveillance, staffing level adequate, and the antibiotic rational usage, surgical patients. So pre-op stop smoking, all this may lead into the prevention of the bundle. Next, please, specific measures. So this semi-recumbent position, sedative interruptions, then oral care, selective decontamination therapy, enterotracheal intubation, subglottic suctioning, suction catheters, nasogastric tube, all will be the specific measure for the prevention of ventilator-associated pneumonia. Next, please. Bundle care of VAP. So elevation, these are 5 points, 5 or 6 points are very important for that is elevation of the head of the bed. It's 30 to 45% is the ideal, 45 degree is the ideal. Daily sedation vacations, peptic ulcer prophylaxis, deep vein thrombosis, daily oral care by 2% chlorhexidine 8 hourly, and the oral instead of nasal tube. These are the important bundle cares. And for the SSI prevention, the bundle care approach includes this hair removal by clipper in the OT, the site prepared by providone iodine or 2% chlorhexidine, this dosage of drug, prophylactic antibiotics, the duration of the surgery, intra-op, post-op glucose level. Intra-op includes the surgery continues for more than is a risk for the surgical site infection, and the glucose level less than 200 is the post-op target. Aseptic technique to be followed, excessive blood loss, patient temperature maintained. All these are the these are the bundle cares for the surgical site infection prevention. Next, please. These are the surgical site infection surveillance form we have prepared. Next. I have already finished the 3 part of the infection control practices, that is standard precautions and transmission-based precautions and healthcare-associated infections due to the devices or the procedures. Now coming, the last few departments are there. That is, there's a supportive areas of infection prevention. That is proper engineering department, properly made infrastructure can really reduce the infection rate or infection it can prevent the infection. Then maintenance department, proper maintenance of the HEPA filters, proper maintenance of the pipelines. All this maintenance department also plays a very important or major role in the infection prevention. Biomedical department, the proper biomedical equipments, proper validation, proper preventive maintenance, all these are the part of the infection prevention. Particularly food and beverage department is an most important part for this infection prevention and control program. And the transportation department includes ambulance. Many other departments are there. Those are the part of infection prevention and control. But as the time is limited, we cannot talk about all the departments or all the areas, aspects where we can where the infection prevention control persists. Next, please. So these are my references. Thank you. Thank you so much. Safety and control is in your hand only.
Thank you, Dr. Jaya. That was a very lucid presentation, comprehensive, and I feel really very, very well put. Due to lack of time and the initial glitches, I think technical glitches, we are sorry about that, but it happens to everyone. So, please bear with us. But it was excellent because you had covered, it was very comprehensive in all aspects. And similarly, the most important points which the participants need to remember, that is what you touched upon. And I think they've done a wonderful job given the constraint in time and, the technical glitches. Thank you so much. And I think there's one question in the chat box. I think Vishwajit Abhirami has asked one question regarding the difference between SAP and post-operative antibiotics. So you would want to answer that?
Can you repeat once, please, ma'am?
Yeah. They have asked, does SAP and post-operative antibiotic mean the same?
SAP. What is that SAP?
I think what he means is basically surgical antibiotic prophylaxis.
Surgical antibiotic prophylaxis. Okay.
Yeah.
Surgical antibiotic prophylaxis is basically to prevent those infections which are caused by the incision during the operation. So basically our skin is having contains the transient bacteria. Those when they get the opportunity, they get invaded and invasive and becomes the pathogen. So although they are commensals, but during the incision they can have. So surgical prophylaxis is made accordingly to prevent the infection due to these transient infections. And antibiotic prophylaxis is the same. That is surgical antibiotic prophylaxis and antibiotic prophylaxis. Coming to surgical antibiotic prophylaxis, depending upon the surgery we are preparing. And antibiotic prophylaxis means according to antibiogram, we are preparing the antibiotic. Normally, like clinical areas, whenever the patient comes with any approach, diarrhea or anything, so syndromic approach we have to go through. As an empirical, what should I give? That is one is prophylactic antibiotic we prepared according to the antibiogram. So surgical prophylaxis is particularly for the surgery, depending upon what surgery, what kind of how long it is going to be. So depending upon the surgical prophylaxis we prepare, and for the normal regular routine approaches like syndromic approaches, we prepared antibiogram and antibiotic prophylaxis.
Right. So I think that's really well explained. So basically, yes. So I'll just like to clarify: surgical antibiotic prophylaxis, as ma'am says, is prophylaxis, prevention of skin, any organisms originating from the skin. And empiric antibiotic therapy is different. That is based on the local antibiogram pattern, and that is what depends what
exactly.
basically guides your empiric antibiotic therapy. Now the question was post-operative antibiotic. Now we do not use antibiotics any post-operation.
Okay, post-operative antibiotics.
Yeah.
Okay.
We do not use
post-operative antibiotics means we do not use post-operative all the time. Post-operative, if it is, first of all, it's the redosing is required in few cases. If the surgery is more than 6 hours, or if blood loss is too much, and if the vancomycin or something, so we have the double half-life, so that time we have to do redosing. Particularly surgical post-prophylaxis is post-surgical antibiotics. Few clinicians, few surgeons prefer, and particularly in case of ortho and all that, but it totally depends upon the clinicians what school of thought they are doing. But nowadays our surgical surgeons are following only 3 days, maximum 3 days prophylaxis.
Yeah. So the other question, Dr. Jaya, is what's your opinion on performing hand hygiene on gloved hands, I suppose. Yeah, that's what.
Hand hygiene
performing hand hygiene on gloved hands.
Gloved hands, yeah. It's not at all recommended as a gloved hand, but in fact WHO has recommended during the COVID, because of the limited resources, that gloved hands also can be like hand hygiene can be done in the gloved hands. But when now we have came out from that COVID era. Still COVID is there, but that severe time and severe era with that COVID, now we have little came out. We can now we should not continue with the gloved hands hand hygiene.
Yeah, that's right. Yeah, that's one. The other thing from Anamika is blood culture bottle should be autoclaved and discarded in which colored bag?
Here, because in the biomedical waste, yellow category, one special category is there, that is pre-treatment is required. So what we are following, all the microbiological items we are putting into the autoclavable bag. We are autoclaving, and we are again disposing in the yellow bag only, because after autoclaving we cannot put into the red bag. It's not recommended.
Yes, the latest Ipc was saying the 5th edition. Hello.
Yes, ma'am.
Yes. According to the 5th edition, that when we are giving for the blood transfusion, everything, when the bag, how we have to dispose?
We are disposing again the same with the autoclave, that whenever the blood bag, it is autoclaving, and we are putting into the yellow bag only.
Again, autoclaving and yellow bag it has to go
Yellow
like
bag
that.
only, yes, ma'am.
Okay, what about the blood discard method, madam? Could you please explain me?
Blood?
After the blood test for the lab, they are having the blood was the blood is there for the left blood. How they have to discard?
Yes, what we are following in our policy, what is there, that in the vacuum also, I think you are talking about the vacuum.
Yes, sir, correct.
So vacuum also we are putting in autoclavable bag at a collective, all the departments, serology and biochemistry, and we are putting into again autoclavable bag. We are autoclaving and putting into yellow bag only.
Yellow bag only, not in the red bag. Am I correct? It is in yellow.
No, few organizations I know, they are putting into red bag also, considering that is the plastic material. But in that case, autoclave is not to be done. But we are doing the autoclaving and we are putting into.
Yes, the red has to go through plastic only. No, only plastic item wants to go yellow. But that is going to blood strain. It has to go to yellow only. Am I correct?
But since the blood is quantity of blood is more, so we are preferring.
Yes. Even body and body fluid has to go yellow, no, madam. That's the reason I asked it. I'm a NA-based coordinator. That's why I'm teaching for the classes. If it is body fluid, cotton, everything goes to yellow. It comes under infection, correct?
Okay, yes, sure.
Hello.
So depending upon the hospital's policy, also many people this is a gray area. So
yes, nice to speak to you, Dr. Jaya.
According to our policy, we have to stick with that.
But ma'am, does it count the urine bags?
Urine?
Because we discard the urine bags in the red bin.
Red bin.
Yes. Urine is what we are doing. Urine we are discarding directly in the bin, and that plastic container we are putting into red.
But if practically see, we that bag also contains the body fluid, so why we do not discard it in?
Particularly it's said, but the urine is not harmful as a blood, first of all, and it is mentioned also many places, many infection control books, guidelines, that urine has to be discarded in a dedicated sink, and then the plastic container, because it's really very risky that all the plastic containers we are sending into yellow and they are going for the incineration. So much furin it will create. So we have to take care of all those things also. So as much as possible, we will put into red. But because blood and blood products are more infectious, so we have to take care of that. So we are trying to balance in between. Yes.
Ma'am, I want to ask one question. Ma'am,
yes,
आवाज आ रही है? Ma'am, in our hospital, we are using.
Yeah, Ashley, please go on.
Okay, in our hospital, we are using the blood culture for the green well. Is it okay or not?
Hello, can anyone repeat, please? Because it was not audible.
क्या हम लोग जो ब्लड कल्चर लेते हैं वो ग्रीन वाइल्ड में ले सकते हैं? Are we supposed to do that?
Ma'am, she is asking if blood culture samples should be taken in heparin vial.
Taken in heparin?
Heparin vial.
Green vial.
That can be discarded. You are talking about discard?
No.
No, regarding the sample collection.
Should we take as a blood
Sample collection, whenever it is required in the heparin, it has to be taken in the heparin EDTA.
No. I'm asking about blood culture. Can we take in that vial?
No, not at all.
Not in the heparinized. I'm asking about only the blood culture that we are supposed to be taking the blood culture, aerobic blood culture.
Actually, are you asking that can we collect blood for culture in a heparinized tube?
No.
Are you asking
blood culture ideally to be taken in the blood culture bottle only, because it contains that broth. Aerobic and anaerobic bottles only, provided by whatever the Bactec you are using, then Bactec, or if you are using the that is Bacteria Alert. So according to the bacterial bottle only.
Okay, ma'am.
Any other questions from the participants?
Hello, ma'am. Blood contaminated gloves goes to which bin?
Blood contaminated
gloves.
Red only.
Red only.
Gloves. All gloves are universally in red only.
Thank you.
Whatever the blood is little, even in OT, it's a lot of blood in the gloves, but it has to be discarded in red only.
Okay, thank you.
Ma'am, can I just ask one question? For this blood bags, autoclaving is the same cycle that we use for other infectious item, or it has to be little different? Because in some references, they say it requires a prolonged autoclaving for the this blood bags.
No. 1 hour is enough. For 1 hour, autoclave.
Yes. Yeah.
So that depends upon your like how much product, how many load you are putting. That we are putting, that is all the vacuum at the same time and blood bags at the same time. So all depends upon the load. If load is less, we cannot use more and more time of autoclave. So we can put together. It's anyway we are going for this 1 hour autoclaving.
Okay.
Hello.
So there's one more question. Yeah, please tell me.
Myself, Dr. Gurjit Singh. I just want clarification on blood bag. Hanji, madam. Good evening. Clarification on blood bag. Shall we use after autoclave? Shall we use the shredding instead of putting in yellow bag or incineration?
Can anyone repeat, Sukanya madam? And
so basically, I think Dr. Gurjit is asking that after autoclaving the blood bags, should it go for incineration or should it go for shredding?
No, whatever we are sending into yellow bag, that will go for incineration only. So after autoclaving, we are sending, after pre-treatment, we are sending in yellow bag only, and that will go for incineration only.
Yeah.
Whatever is going by red,
so for
that will go to third party, and there they will autoclave and shred.
Yes, Dr. Gurjit, please let.
Okay.
Is it clear?
No, I am just asking that if you go for incineration, then there is they contain plastic, na? These are the bags are plastic bags. So for that they produce some kind of furans, and I think for
That's
that
right.
purpose we avoid incineration instead of yes.
Yeah, so basically there is an MOU with your vendor, the state vendor, Dr. Gurjit, and whichever plastics are thin and which can be basically given for incineration, those specific plastics only will be taken for incineration. The other thick plastic bags like your blood bags will obviously go only for shredding, because they would release a lot of these fumes which can cause a lot of pollution. So I think basically, as Dr. Jaya told, we have to go as per the local, because every state has got their own guidelines and all that. So if in any state in which you are, it is important for you to be in alignment with the state pollution control board ka guidelines. We do have a central pollution control board which gives broad guidelines, but if you look at some of the liners also, there is a change in liners for general from state to state. I think in Punjab it's green, whereas in South it's black. So there's something little bit of a lot of variation is there throughout the nation. So I would generally suggest and advise that go as per your state pollution control board policy and ensure that the MOU which you sign with your central biomedical waste collector, right, also follows the same state pollution control board policy. Also, it is imperative that we visit and we review the MOU. We try to visit the final disposal site at least once in 6 months, so that we are aware that they are in alignment with the state pollution control board.
Yeah, correct.
There will be definitely gray zones, as Dr. Jaya said, because if you're in Calcutta, if you're in Punjab, if you're in Gujarat, if you're in Mumbai, if you're South, there will be a lot of differences. But the fundamental practice is that everything which is in yellow generally goes in for incineration. Anything which is in red generally goes in for autoclaving. That's a fundamental basis which the CPCB has laid down. But again, which plastics, even after you autoclave, now microbiology waste, as Dr. Jaya said, definitely goes into yellow as per the latest biomedical waste. Now, but again, microbiology waste, if you look at some of the plastics which we use in microbiology, some of them are very thick. So obviously they cannot be incinerated. They will have to be shredded after autoclaving. So that again is a call which is taken by the State Pollution Control Board and the final disposing authority. Fine. So just be in alignment with what your State Pollution Control Board is telling and what is your local vendor doing. I think I hope I'm clear.
Thank you, ma'am.
Yeah, thank you. Yes, please.
मैम, तो आप ये बोल रहे हो जो ऑटोक्लेव जो करता है उसके बाद भी वो येलो बिन में ही जाता है. I'm right?
Autoclave is actually, yeah, that's right. No, autoclave, see, basically, Ashley, the thing is, this is always a gray area because generally what we always follow is that all plastic waste goes into red, correct?
Okay.
Right? Because plastic should not be incinerated. That is the principle. But as per the new biomedical waste guidelines, microbiological waste, which is considered as infectious, okay, especially now during COVID times, they are telling to put into yellow bag. Okay, right. So, aap yellow bag mein dalenge, you will be autoclaving it, right? But obviously, after autoclaving it, it is rendered as non-infectious.
Okay, ma'am. Why we need to maintain shelf life of sharp container? I think it's 72 hours.
हाँ, वो भी एक gray area because in Karnataka, if you look, it is 48 hours. In some of the other states, it is 72 hours. So again, there is a deviation in the shelf life of,
What is the criteria? Like, there is any special? Ma'am, what is the reason behind it? Why we need to maintain shelf life of?
You don't have to maintain. It's not maintain. It is maximum amount of time for which you can keep is this much hours. It's not that you have to keep sharps for 48 or 72 hours. They say the limit for at which you can keep the sharps is only 48 or 72 hours.
Maximum time you can retain.
For example, if my unit having 7 or 8 patients and and एक बड़ा sharp container रखा हुआ है, 3 liter का sharp container रखा है and it's not even fully
getting filled up. हाँ, तो वही है ना, आप तो 1.5 liter का ले लीजिए ना. Take it 1.5. Take 1 liter.
Small size.
So, ma'am, in this case, can we follow the markup policy, the third, fourth policy? Like if there are marks on the sharp containers for which it has to be filled, and then we can discard it.
75%.
No, always please remember that you have to follow the Central Pollution Control Board guidelines or the State Pollution Control Board guidelines. If your state says is the maximum limit at which you can keep sharps is 48 hours, then you need to dispose of sharp containers after 48 hours, regardless of whether it is full or not. So, if you feel that you are wasting your sharp containers, यदि आपको ये feeling हो रहा है, तो आप छोटा सा sharp container ले लीजिए. That is a better option because we cannot violate the Pollution Control Board ka guidelines.
Yes.
Okay. Yeah.
According to your load, you have to take the smaller size.
Yeah.
Thank you, ma'am.
Any more? Yeah, no problem. Any other questions? Okay, Dr. Jaya, there's one more. I think from Vishwajit. Okay, there's one. How do we discard X-ray films? Dr. Jaya, you want to take up that question?
Yeah, sure. So what we are doing in that this thing, they have not mentioned anything about those things like X-ray films or X-ray that reagents and all those. They have not mentioned in the latest guidelines. Also, there is nothing is there mentioned. So what we are following, that all these things, X-ray films and all those, we are giving this. The e-waste department is there. So we are giving along with the e-waste, and they are again they are giving back to the this third party.
Correct. That's right. Because X-rays films are not infectious or anything, so you really don't have to regard it as an infection.
Actually, these are not e-waste, but we are categorized as a like the whatever e-wastes are there. Along with that, we are putting. There is no other options we didn't find.
That's right. Okay, the other question, Dr. Jaya, is MRSA screening needed as a checklist before surgery for surgical patients? This is from Mr. Vishwajit.
Checklist కావాలి madam.
Before surgery. Our surgery.
All the surgeries, it's not mandatory, we believe, but it depends upon the policy of the hospitals. Like a few hospitals, they particularly do does for the transplant patients. Definitely, they have to do. But the other regular surgeries, that all totally depends upon the hospital's policy, because again it will cause a extra burden for the patients also. So that depends upon the what surgeries are for posted and hospital's own policy.
Right. So the other question is from Dundee Yoon. I would like to ask about VAE prevention. If the patient with ventilator is on anticoagulant, is it acceptable that we don't apply intermittent compression machine on their legs?
So yeah, not only that is one part of the bundle care.
Correct.
So the other things we can do.
That's right.
Other bundle cares, that those 6 points are there, those 6 cares, 6 bundles are there. So all those we can do, but whatever is the we cannot do, that we can leave, and the other things we must do. And maybe compression we cannot do, but manually we can do some pressure, so that at least that coagulation part will not be that much. Coagulation will not happen.
That's
but
right.
other bundles has to be followed. The other bundles.
That's right. Okay. So if blood bags are Ashley, yes.
Ma'am, how can we manage mercury spill?
Mercury spill, nowadays mercury instruments are not at all there. If you have, then the similar
biomedical, maintenance.
Yeah, biomedical, exactly. And if spillage happened, then you have to collect it like in a syringe, and just like immediately, just like cleaning like a normal spillage, and immediately inform to the biomedical as well as the infection control department also.
Ma'am, if it is large mercury spill, then how can we collect?
Biomedical, you have to inform and take. But large, how will you get this much of mercury now?
Like I'm asked, just have a query, like if it is.
Yeah, actually nowadays we don't use mercury at all. In fact, it's being effaced out.
We are not doing more.
Yeah.
In the hospitals.
So there is, even if there is a mercury spill, there is no question of it being a large spill, because with the amount of mercury in a thermometer or in a BP apparatus is obviously very less. So there is specific, if you are still using mercury, then you need to, you can go to the hazmat site. There is a method of dealing with mercury spills. If you have mercury in your hospital, in any instrument or equipment, you need to have a mercury spillage kit, and you should know, and you should train your people on how to handle mercury spills. But nowadays, generally, it's being effaced out. So you could refer to that.
And then the cytotoxic spill, we can manage with soap and water.
Cytotoxic spills?
Yes.
With soap and water?
I'm just asking if can we manage?
No, you can't. There are specific protocols for cytotoxic spills. Okay, management is not only just washing off the area, Ashley. It is basically addressing how you need to discard the waste once you take it out. How do you need to, whom do you need to inform? Where do you need to do a final disposal, etc. So cytotoxic spills, mercury spills are specifically hazmat areas, and that should have, if you are, interested in that, then we need to have a separate session on those specific things.
Okay.
It comes under hazmat. So we can probably discuss that later, but there are specific protocols for cytotoxic spills. It cannot be managed with soap and water alone.
Okay, ma'am. Thank you.
Yeah. Alka has asked something. Basic regulatory biomedical waste guideline. Yes, Alka, basic regulatory biomedical waste guidelines has to be followed in every state, which is in alignment with your Central Pollution Control Board. It cannot be different. Only thing is, every state pollution control board may define slightly differently the type of liners, the color of the liners, and how to do a final disposal. A slight variation could be there. So that is the reason why I told to follow this particular state pollution control board guidelines. It will definitely be in alignment with your basic regulatory, that is CPCB guidelines. I hope I've answered your question, Alka. Okay. So cytotoxic waste, basically I've already answered this. Okay. And opening, somebody has asked, I would like to ask on the opening and discard dates for PPCs. Can you please explain what is PPC?
PPC, I think puncture proof. She's
puncture proof.
mentioning about
Okay. ठीक है. PPC, as you mentioned, it is 48 hours or 72 hours, but is mentioned 48 hours for human anatomical parts in the guidelines. So human anatomical parts different है ना, sharps तो different है. तो आपके guideline में whatever is there in your pollution control board guideline, which defines what is the time limit at which you can stock your sharps in locally, you have to follow that guideline. I didn't really understand this question. Naveen, is your query clarified, or do you still have some issues or some confusion regarding this?
Ma'am, hello. Good evening, ma'am.
Good evening.
So I have read the guidelines where it is mentioned that you previously discussed regarding the same question, how long we can keep the puncture-proof containers, whether it is 3x4 filled or do we need to use the smaller containers so that they can fill faster compared to larger containers.
Correct.
So my query is like they said, it takes few nursing stations, it takes 1 day or 2 days, but few areas it takes more time to get 3x4 filled.
Correct.
So that time we can keep the smaller size of PPC in those areas.
Yeah.
Okay, ma'am. So I mean, maximum time allowed to keep the PPCs, ma'am.
Maximum
time
time
of using today.
In some few, that's what in few of the states it's 72 hours. In few of the states it's 48 hours.
Okay, so it is mentioned in the guidelines, ma'am. Like
yes, definitely. It is mentioned in the guidelines.
Okay, ma'am.
Whichever
So
state you are in, that particular state pollution control board defines the limit of duration of storage of your sharps.
Okay, ma'am. I'm from Telangana, so I have read the guidelines.
Okay.
So, but I am not able to find the point of this thing.
Okay, then I will. We can share that with you.
Sure, ma'am.
Yeah.
I am from AAG hospitals, ma'am.
Okay, Naveen. Definitely, we'll share that. Whatever information Dr. Jaya gets or I get, we will definitely put it across to you through the SANMED platform.
Sure, ma'am. Sure. Thanks a lot, ma'am.
Okay. Anamika has asked for biomedical waste. Yes, I think that's a very important requirement. The way the session is going, I think we need a separate session on biomedical waste. There's a lot of gray areas, and probably we can have a discussion on state pollution control board, variations compared to central pollution control board. Yeah, we'll definitely do that, Anamika. Very good point. And specific indication for double gloving, Dr. Jaya, do you want to take that up?
Yeah. Double gloving is required in a few guidelines. It has been mentioned that if you know the patient is seropositive case, then it is better to use the double gloves. Not always, but few guidelines I have seen, or just one or two. But double gloving is required for the known seropositive cases, so that it may give some protection. And even if we see the needle stick injury also, we have seen that is protection prior to giving the injection and all that. Gloves must be there, not bare hand injection and all that. So gloves can give you some protection. So similar way, maybe just double gloves for the non seropositive, it will be helpful for protection, further protection.
Yeah, so if there are no more questions, then does anybody still have any questions? We will definitely, take into consideration a separate session on biomedical waste, definitely. But whatever ma'am has covered in this session, any other specific challenges or any queries you all have? If not, I think we'll close the session for now, because I think it's way past the predicted timeline. And thank you all for a very interactive participation, and especially Dr. Jaya for putting up with all these technical glitches and still delivering an excellent presentation. Thank you all so much.
Thank you everyone. Bye bye.
Yeah. Bye.
Thank you, madam. Thank you so much.
Thank you, Doctor. Thank you, Dr. Jaya and Dr.
Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you.